Severe community-acquired pneumonia, or Scap, is an acute, high-stakes infection of the pulmonary parenchyma. It is also a leading source of diagnostic error. Between 10 and 30% of patients diagnosed with it in the emergency department do not actually have the disease. For the patients who do have it, clinical management often falls into a dangerous trap. Physicians rely on generic ward protocols and standard fluid boluses triggered by isolated lactate levels, a marker often associated with tissue hypoperfusion. This treats the numbers on a monitor rather than the primary disease process. The point of failure arrives quietly. A patient appears stable on the medical ward, requiring only supplemental oxygen, until they suddenly crash. The cause is rarely a sudden burst of bacterial replication. It is an unrecognized compounding respiratory exhaustion. Preventing these systemic collapses requires discarding passive observation. We have to adopt a modernized three-pillar protocol for Scap management. Pillar 1 replaces traditional mortality scores with physiological severity assessments. Pillar 2 replaces broad-spectrum antibiotic blasting with radiologic pattern recognition and rapid diagnostic de-escalation. Pillar 3 integrates recent clinical trial data to re-rate the rules on host immune modulation and respiratory support. True survival in severe pneumonia is dictated by what happens in the first 24 hours. It requires proactive ICU-level critical care from the moment of admission. The initial disposition error begins with tools like CURB-65. CURB-65 is a clinical prediction rule estimating the 30-day mortality risk for pneumonia based on confusion, urea, respiratory rate, blood pressure, and age. This chart shows how a low CURB-65 score fails to track immediate physiological strain. Because the tool was validated exclusively for long-term mortality, it is functionally blind to a patient's immediate need for critical care intervention. The correct framework for bed placement is the Infectious Diseases Society of America and American Thoracic Society criteria, the IDSA/ATS Severe Pneumonia Framework. The pathway is divided into major and minor criteria. The major criteria dictate that if a patient requires mechanical ventilation or presents with septic shock, they go directly to the ICU. But the minor criteria are where clinical judgment matters most. If a patient presents with any 3 minor criteria, which include confusion, multilobar infiltrates, or specific lab abnormalities, they meet the definition of severe KAP and require the ICU. Triage often fails because of hidden hypoxia, a state where oxygenation numbers look acceptable, but the muscular cost to maintain those numbers is unsustainable. A patient maintaining a 94% peripheral oxygen saturation, or SpO2, on a nasal cannula might appear fine on paper, but if they are exhibiting a respiratory rate over 29 breaths per minute to achieve that saturation, they are an acute failure. Accurate triage evaluates the physical trajectory of respiratory exhaustion. The isolated oxygen saturation number on a monitor is a lagging indicator. This assessment must also integrate clinical history. Recent epidemiological factors or inhalational exposures, like the initiation of vaping, can precipitate a severe pneumonitis that drastically accelerates the timeline of respiratory failure. The IDSA-ATS criteria force clinicians to measure real-time physiological strain. You are anticipating the crash rather than reacting to a mortality statistic. Moving to the second pillar, microbiological cultures take days to return, but initial empiric therapy cannot wait. A computed tomography, or CT scan, allows us to map the lung's internal architecture in real time. This is the classical lobar pneumonia pattern. It is defined by large, dense areas of consolidation that spare surrounding tissue, often accompanied by visible air-filled bronchi, known as air bronchograms. This distinct architecture strongly suggests specific bacterial pathogens: Streptococcus pneumoniae, Haemophilus influenzae, Klebsiella, and Legionella. Occasionally, the sheer volume of inflammatory exudate expands the affected lobe, bowing the anatomical fissures outward. This bulging fissure sign is a hallmark of high-pressure, virulent bacterial expansion, classically associated with Klebsiella. The opposing radiologic pattern is bronchopneumonia, characterized by patchy, multifocal opacities and diffuse ground glass patterns, indicating endobronchial spread.
In this pattern, the clear airway outlines of air bronchograms disappear entirely. This scattered architecture shifts the differential diagnosis away from classic lobar bacteria. It points toward viral pathogens like influenza and RSV, atypical bacteria, or invasive Staph aureus. Recognizing these patterns drives diagnostic stewardship. It ends the practice of giving every patient maximum broad-spectrum antibiotics indefinitely. This brings us to the specific utility of targeted testing. We use polymerase chain reaction, or PCR, to detect specific genetic material. For Scap, a Nair swab for MRSA PCR dictates our coverage strategy. The MRSA PCR carries a massive 96 to 99% negative predictive value. A negative result effectively rules out MRSA as the cause of the pneumonia. The protocol rule is strict. If the PCR returns negative, anti-MRSA coverage must be de-escalated and stopped within 48 hours. Pairing radiologic phenotypes with rapid PCR testing delivers a precise empiric strike, minimizing toxicity and preventing resistance. The final pillar updates our therapeutic core, anchoring respiratory and host immune support entirely on recent, high-quality clinical trials. For severe hypoxemic CAP, the Florally trial shifted the standard of respiratory support. High-flow nasal cannula, or HFNC, reduces the patient's work of breathing through dead space washout. It continuously flushes carbon dioxide from the upper airway. Critically, HFNC does not seal the patient's mouth or nose. This preserves their mechanical ability to cough, speak, and physically clear purulent sputum from their lungs. This highlights the clinical trap of using bi-level positive airway pressure, or BiPAP, for pure pneumonia. BiPAP uses a tight-fitting mask to push pressurized air into the lungs. BiPAP will temporarily stabilize the patient's oxygen numbers, but it actively prevents secretion clearance. The trapped mucus builds up, inevitably resulting in massive mucus plugging and catastrophic respiratory failure. Beyond respiratory mechanics, we must modulate the host immune response. This is guided by the findings of the Cape Cod trial. This graph charts the recommended corticosteroid therapy. Based on the data, the definitive guideline is 50 milligrams of intravenous hydrocortisone every 6 hours for true severe CAP, tapering off quickly over about 8 days. We are not administering this to chase abstract mortality statistics. The objective of the steroid is explicit: reducing the length of stay in the ICU and severely cutting the risk that the patient will progress to mechanical intubation. Finally, we must correct a lethal error in hemodynamic resuscitation. Do not reflexively dump large volumes of intravenous fluid, 30 cc's per kilo, into an SCAP patient simply because their lactate level is elevated. The lungs are already failing due to inflammation and fluid buildup. Forcing large fluid volumes into the vasculature directly worsens hypoxemic respiratory failure, driving the patient straight to a ventilator. The required strategy is early initiation of a low-dose vasopressor, like norepinephrine. This stabilizes organ perfusion without drowning the lungs in fluid. Modern therapy is an exercise in restraint and precision. We wash out dead space, modulate the inflammatory response, and strictly restrict fluid volume. By combining these 3 pillars, we construct a cohesive, sequential workflow for every newly admitted SCAP patient. Step 1. Execute proactive physiological triage using the IDSA ATS criteria. Catch the hidden hypoxemia and elevated work of breathing before the muscles exhaust entirely. Step 2. Analyze the radiological pattern to narrow the empiric antibiotic target. Then enforce aggressive de-escalation by dropping MRSA coverage within 48 hours based on negative PCR data. Step 3. Support the physiology. Immediately implement high-flow nasal cannula, begin hydrocortisone, support hemodynamics with early vasopressors, and avoid large fluid boluses. Even with this protocol, remain skeptical. Do not assume septic shock and chest opacities guarantee pneumonia. Actively investigate to rule out structural mimics, like pulmonary embolism or acute heart failure. Above all, discard the outdated habit of using long-term mortality scores, like CURB-65, to dictate immediate bed placement. Implementing these strict data-driven parameters moves SCAP from a reactive ward emergency into a controlled, highly survivable intensive care pathway.